thank you very much for joining us here in the Royal Aeronautical Society. Particular thanks to those of you who are joining us in person, but also joining us online. But a lovely online audience from around the world, so that's great. Global presentation for a very timely subject. I have to confess, when organising it, I did think it would be more pertinent to our ongoing debates. Since then, the world has changed yet again, so perhaps not the topic which I thought would be, as on the nose as initially, but I'm still very much excited to have it. Because I think it's a really interesting topic, and it's one I don't know a lot about. So that's always a sign for me to get engaged. So I'm really pleased to introduce Dr. Gemma Bowsher, who is a social scientist working on global health security with a focus on health security intelligence, civil military cooperation, and public health in conflict settings. She is the co-principal investigator for the Health Intelligence and Biosecurity theme at King's College London, at the Department of War Studies, Conflict and Health Research Group, and she's also an affiliate member of the KCL Centre for Science and Security Studies. Her work at KCL focuses on health security intelligence, linking clinical domains with intelligence processes within national and international government systems. She works with organisations and researchers across defence, academia and public policy. I'm really excited to hear this lecture, so Gemma, please take it away.
Thanks very much, Harry. Sorry for the mouthful of, it's a lot of jargon and stupid words in that bio, but thank you very much, and thank you very much everyone who's here in person and online. It's still, I think, quite fresh coming back to in-person events, but it's very exciting, and I'm very grateful to the RAF Museum for allowing me to be here. And obviously, you can see the talk is on the RAF and the evolution of global health. I do think it's still just as pertinent as it ever was, and I hope to be able to explain to you tonight and make the case that it remains. The RAF and Defence Medical Services in conflict is one of the most pressing and urgent policy issues and technical issues that we have to this day. I will start with a caveat before things really get going, that I'm not a historian. I'm a boring old medical doctor who works on global health science. I'm a scientist, but I have had to go to archives and I have had to do some historical research for this project. But don't hold me to the very high standards of historical accuracy and scholarship that I'm sure you have. Although everything I'm saying tonight, of course, I do hope to be true. But anyway, so the question of why I decided to move into this, so you can see the slightly fine-grained picture here. I start off with a story of my lockdown. So I was having a day off. I think it was kind of in the early gap between the first or second lockdown. And I was looking to redecorate my home. And I specifically wanted to find a nice painting for my living room. And so I ended up on all the websites. And apparently vintage stuff is very fashionable at the moment. I'm not that fashionable, but I'm told it is. And I found this advert for huge vintage military hospital sign, 7 meters. And if you can see, it's hard to read, but it says, huge vintage sign originally from RAF Halton in Buckinghamshire. This may be a slightly unfortunate piece to be selling during a global pandemic. So my interest was piqued. I didn't know about RAF Medical Services, but a colleague of mine in global health said, oh, I did some work there. And another one said I was born there. So I thought there must be something to this story. So I started doing some investigations and discovered the fascinating history of the RAF Institute of Pathology and Tropical Medicine, which had been based at RAF Halton. Through the various twists and turns in the tale, I discovered a number of other important elements that I think resonated very clearly with the ongoing COVID-19 pandemic and my own experiences in clinical work and my own experiences working in health security at King's and in other settings around the world in conflict. So I thought, okay, fine, let's try to connect this important history with the RAF with the issues we have today. So although there's a important historical element, it's very much a forward-looking investigation. And here it is in all its glory. It's hard to make out with the sunshine, but you can see the sign on the old original building at RAF Halton and the crest of the unit with its motto, Nil nisi veritas, nothing but the truth. So this is the old RAF Institute of Pathology and Tropical Medicine. And the story of this unit, I do believe, is an important one. COVID-19 has yet again thrust disease and illness to the forefront of international politics, and of course it's altered all of our lives. Public health done well so often goes unseen, And I think that is also true for the history of these important places that play such important roles in the technical and innovation developments that we all benefit from. And I think throughout COVID-19, we've also been forced, all of us across medicine, healthcare, all sorts of sectors, to focus on and think about, whether we've liked it or not, the boring technical bits of day-to-day outbreak response and clinical delivery. And militaries have always been important agents in developing innovation in medicine and in epidemic response. So, for example, antibiotics, blood transfusion, renal dialysis, trauma care and networks, radiology. I could go on, but these are all innovations of war. And more importantly, they're all innovations of military medical science that we all benefit from today, importantly. And the RAF too has an honoured, but I think in the public sphere, relatively neglected place in that history. So most frequently we hear about the tremendous innovation driven in settings such as burns care, such as by Archibald Mackindoe at East Grinstead, which is fantastic and incredible work and rightly deserves the attention it's deserved. But less visible has been the RAF's important work in tropical medicine, now more close to what we'd call public and global health, which is my area of practice. So as we face this stage of a global pandemic, I think it's very important that we reflect on how militaries and publics and society as a whole tackle these challenges. And much of the effort in my field is going into evaluating how we can better integrate military, civil and humanitarian responses to health emergencies, looking at examples of COVID. But I think if we look back further, we can see even better examples of practice. And my hope is that by tracing the story of this unit and some of the people and individuals and areas of interest associated with this unit, we can draw some lessons to think about the future and to strengthen future practice across civil and military healthcare delivery, which is what I spend my days having to do. So, to talk in any meaningful way about the Institute of Pathology and Tropical Medicine, we have to talk about this man. This one man in particular is Air Marshal Sir Harold Edward Whittingham, who is a figure very well known for his exceptional contributions to the field of aviation medicine. We turn, however, not to his very important contribution to aviation medicine and the physiology of aviation. That is a fascinating story, but it's not the one we're going to think about tonight. We're going to turn to his early career, to 1917, when as a young man in the Royal Army Medical Corps, on loan to the RAF, Captain Whittingham established the nucleus of what would become the RAF Central Laboratory based at Finchley and what subsequently became at Halton, the RAF Institute of Pathology and Tropical Medicine. He wrote very eloquently. He was a passionate note taker, which is very helpful for amateur historians such as myself, because he does a lot of the work for me. But he wrote of his early undertakings in lab establishment, which again are quite shocking, but we've all been through the kind of ad hoc nature of an early crisis. So he wrote, at first there was neither assistance nor apparatus. An improvised incubator and hot air oven were made from biscuit tins. An ordinary saucepan and steamer were used for preparation of media. After a period of 4 weeks, apparatus and articles intended were received by the unit. So we can see the piecemeal nature of the early RAF Central Laboratory and the early efforts that this man had to establish to deliver anything resembling pathological services for a whole sector of defence, the whole of the Royal Air Force. But heading into 1918, as the war came to a close, it was felt that the work had been good enough and had been impressive enough that the RAF finally merited its own dedicated service. And from then on, all of the work for this kitchen laboratory was directed at the Air Force alone. And they brought Whittingham over from the Army and convinced him to remain in the Air Force, which he did until the end of his career. I wanted to simply show you some of the pictures from his early notebooks, because for those of you who are more medical, I think there's an important personality trait that comes through very clearly from his notes. He was a pathologist by trade, and there's jokes amongst all the specialties about different personality traits that are apparent across the specialties. And I think no pathologist would be upset if I were to say that they're known for being detail-oriented and potentially obsessive with details, which is important in their work. I'm a boring old orthopod. I deal with broken bones, and it's not what we're famous for. But his notebooks are incredible documents for his early investigations and his obsessive collection of disease. You can see his sort of fundamental passion for recording everything he sees and trying to make leaps in understanding. He writes very eloquently across the notebooks about all sorts of things from diseases that we don't see. He's wrote about smallpox, rabies. He writes about almost any disease under the sun. Plague. They're based at the Wellcome Archives, and you can spend a very happy day looking at his very detailed drawings as well. But of course, in 1918, along with the end of the war, another important event occurred that changed the face of Defence Medical Services and RAF medical services. So the pandemic of Spanish flu carried on from about February 1918 until April-ish 1920, and infected about 500 million people, which was believed to be about a third of the world's population at the time. And that was in 4 waves. Up to about 40 million people are believed to have died. It's one of the sort of it's not quite a medical mystery, but it's believed that it was the H1N1 strain or a variation of that, which remains kind of scourge of flu medicine and a great worry on global stages. So, over the course of 100 years, we still remain worried about pandemic H1N1. But by the beginning of 1918, the height of the pandemic, Whittingham's work at RAF Central Hospital had so increased that the one small room he was allowed in the laboratory was found to be inadequate. So he was allowed to move into another room, 2 whole rooms, to deal with a pandemic for the RAF. And he was allowed to employ small people, and he was quite open to employing people of all genders, and he had a very heavy female component, which was pleasing for me to see, who stayed dedicated to the unit for the whole of their careers. So individuals such as a woman called Minnie Sage spent her whole career at the RAF Central Laboratory working on pathological services. So I think an impressive early undertaker of gender equality in RAF medical services. But he wrote very, again, passionately about his work, and he wrote in his operation logbook of the pressures of attending to Spanish flu, and from this very small, overstretched, essentially kitchen-based military laboratory. He wrote, in the middle of June 2018, the great influenza plague reached its climax. The staff was worked to its utmost in carrying out the routine work, and at the same time doing exhaustive research into the cause and general pathology of influenza. Scarcely was the epidemic over when another wave broke out, so that further help was necessary. Experimental work on animals had to be carried out. I think a lot of what he says resonates very clearly with those who've been working in the current pandemic, this issue of multiple waves constantly placing demands on overstretched staff with limited resources. Not much has changed in 100 years, and certainly with what was then as now, new emerging pathogens. It's important, I think, that we think of actually the sheer challenge dropped on these individuals, having come out of one war and all of the challenges placed on military medical services then directly into an enormous generation-altering pandemic. But the staff at Hampstead carried on, and they worked at great pace. And he was acutely aware, Whittingham was, of the medical threat that diseases such as this posed, the medical threat that it posed to the operational capability of military medical services. And so Whittingham set about developing a very strong research agenda, because he realised that this was an important area for Defence Medical Services and for the RAF to take seriously as an issue that could compromise the capability, the core operational capability of Air Force centres. So he actually has published what's believed to be the earliest case series of the pandemic influenza of 1918 in the BMJ, and he collaborated with a Royal Naval colleague as well, documenting a study of the first 50 cases of influenza occurring in the Royal Air Force. So this was a man who was at the forefront of work on the ground, where it needed to be, and thankfully made many notes on the subject, which we can all benefit from now. I wonder what we'll be thinking in similar times in 100 years, looking back at the coronavirus notes. So I think, again, we forget it's easy now as seeing sort of the NHS at the forefront of medical care here, it's easy to forget the importance of military medical services at the time. At the time of the pandemic in 1918, about half of medical doctors, the medical profession, were employed by the military. And that was because they were conscripted for the war effort. So in some ways, the military was the core operational medical capability of the whole nation facing a pandemic. Obviously, it had been eroded over the course of the First World War, but that central capability was very, very much remained at that stage. And it's important because military medical services have so often been involved in developing these early innovations to outbreaks and outbreak response. And I think one of the other key lessons that I think has come out from some of the COVID work has been the importance of the cross-fertilization between sectors and the ability for civilian medicine to learn from military medicine and military medicine to learn from civilian medicine. And there should hopefully be some crossover. That's hopefully some of the work that I've been working on, but that's for another time. But another important activity that Whittingham led and really characterised the whole work for the whole history of this unit was vaccine development. There was a real bun fight to develop vaccines and to develop a vaccine for the Spanish flu. And the army sort of had the lead role in this. And the War Office with Sir William Booth Leishman had established what it designated to be the standard vaccine. But as we all know now, vaccines can be controversial and political, and people can have their preferences. And Whittingham was no different. And he decided he didn't like the War Office vaccine, and RAF servicemen were not going to receive it. So he came up with his own, which wasn't that unusual because most microbiologists would have their sort of pet concoction of vaccines. But what Whittingham had was a laboratory that was able to develop it and deliver it at considerable scale and pace. Now, the sad result is that, unfortunately, none of the influenza vaccines were particularly effective in any way. But what Whittingham learned was that he could develop vaccines, and that he could develop vaccines and he could supply them to the Royal Air Force. And that became an essential capability throughout the whole course of the work of the IPTM, developing, producing and supplying vaccines and responding to the epidemiological requirements of the population, surveilling them, investigating their outbreaks, and then delivering vaccines where they were needed. And we see that up until today in various ways. So the Spanish flu was an important moment for this fledgling laboratory. We can see that it was important in general politics, but it was more important, I think, in military medicine. And I think the RAF had an important focus on, as it moved into more of a field of aviation characterizing warfare, so how militaries can direct their efforts in vaccination and beyond. So he was also involved, he was a man who traveled a lot, and the RAF clearly had a highly dispersed ground operations. And so he had to tackle diseases all over the world. And I could pick lots, but he was particularly prominent in the investigation of a disease called sandfly fever. And I think what's important to draw out again is that military medicine quite naturally focuses on the important issue of force protection. And it still does today, and of course that should be a core responsibility of any undertaking in military medicine, to protect its troops from threats, physical threats, and to protect its troops from bacterial, viral, fungal, pathogenic threats of all kinds, ones that we know about and ones that we don't. And that's no small feat to do across the very many environments and ecosystems that militaries travel. So once the Great War and the pandemic of Spanish flu had receded, this fledgling laboratory did have to turn its work to the important but more ordinary work of outbreak response. And there was this important disease was affecting the troops that were based out in Malta and Iraq. The challenge of sandfly fever, which is a vector-borne disease spread by these sandflies, was an important one because it occurs in subtropical regions where the RAF had a heavy outposting. It's a fairly, I say mundane, it's not a mundane infection in the sense that it has a fairly low mortality but quite a high morbidity. So you become febrile for a few days, you have myalgia, abdominal pain, you're out of it, you feel quite fluey for a couple of days up to a week. But like COVID, it also can manifest in longer term symptoms. And the physiology and pathology of that process was not understood at the time, but it was understood to be costing the RAF an enormous amount of money, enormous amount of service days, and to be costing labour to the Royal Air Force, which couldn't go on. So Whittingham was clear that this disease was one of the chief causes of inefficiency in the whole RAF in the post-war years. So something needed to be done, and so they called the pathologist. So off he went to Malta, and he was appointed, now squadron leader Whittingham was appointed head of the RAF's Sandfly Fever Commission to discover as yet, it was known that flies are implicated, but there was very little understanding of the mechanisms of illness, the vector-borne transmission patterns, the general epidemiology. This graph is his hand sketching of the pattern. It says the chart showing the curve representing the monthly case incidence of sandfly fever over total sickness of the RAF. So you can see there's a trend there, and he was sent out to investigate what this trend actually meant in practice on the ground. So quite a big challenge, especially when you consider that he didn't have all the fun tools and tricks we've got. He didn't have computers. He didn't have all the pathogens and testing stuff that we have today. But it is extraordinary as a case study in outbreak investigation, and as well as his sort of now rigorousness in undertaking the project. So his work in the Sandfly Fever Commission did identify the chief vector of disease, and it did clarify the routes of transmission. His experiments involved a range of different techniques in Malta and at the IPTM, which ranged from breeding sandflies and capturing them, as you can see in these boxes. He developed approaches to fumigation, which at the time he had been used a little bit for malaria as well. He developed these specialist breeding grounds to develop sterile conditions to breed sandflies, so he could conduct his own experiments to purposefully infect them and investigate the kind of entomology of the sandfly. And he makes some beautiful detailed drawings. He also carried out some experiments which certainly would not receive ethics approval today. It was not, I say this is a twin, it was not a good time to be a twin in the Royal Air Force, because Whittingham would find you. And if you're a twin in the Royal Air Force, he would purposefully infect one of you with phlebotomous fever and see if the other one naturally caught it, and to investigate so-called studies in life to see how you both got on and how you fared with your shared disease of phlebotomous fever, which twin studies still do remain a very important tool in the medical arsenal for very specific kinds of things. I've participated in them myself, but this kind of study, it doesn't happen these days anymore, thankfully, and hopefully not, at least. To be fair, he did also infect himself, in case there's any question of his commitment to the work on sandfly fever. But I think it is worth drawing out that these kinds of military investigations, such as the Sandfly Commission, although they're established with a very clear force protection imperative, and that's the sort of rationale for deploying them, they've been vital scientific endeavours that have contributed more widely to our fundamental understandings of disease dynamics around the world. Malaria too, for example, has been subject to similar work. We could talk about malaria, we could talk about plague, we could talk about yellow fever. You could write a book on every single disease and consider only the military contribution to the development of the fundamental science that informs our daily drugs, treatment protocols, and management approaches, and even the diseases that don't exist anymore, such as smallpox, for example. So these small investigations contribute enormously to the overall success of military medical services, I would argue, in outbreak investigation and in disease control more broadly. And I think we neglect that wealth of knowledge and expertise at our peril. Another very important and timely area that we pick up on from Spanish flu is Whittingham's obsession with vaccines. And he was pretty obsessed with vaccines, especially in the interwar years. I think his experience from Spanish flu very much informed that understanding and that undertaking the tasking of the Royal Air Force IPTM with vaccination. So alongside outbreak investigations, that formed a core pillar of the work of the RAF Central Laboratory, which in 1935 was finally renamed, as we know it, the RAF Institute of Pathology and Tropical Medicine. Again, the vaccination drive was for force protection, but this convergence and this collision of basic science research and force protection occurred once again. I think the successes and failures really of the Spanish flu program kind of reinforced the need for militaries to have a rapidly deployable capability to tackle new pathogens. I think as services were moving into new geographies, it was understood that actually vaccines could form a core weapon in the arsenal of militaries globally. A tool that others didn't have to protect their forces and to maintain the fighting force moving into new territories. There was also economic forces at play. So Whittingham himself wrote that he said if the RAF bought in instead of making their own vaccines, the cost would be about £835 per annum. So that I tried to sort of tot it up, and don't hold me to it. I said I'm not a historian, but that's only about, by my numbers, about £60,000 in today's money, or not accounting for inflation. And as I said, I'm not an economist either. But even that's not that much money when you consider the cost of vaccines these days. But at the time, that obviously was an awful lot of money. And so he said, you know, the cost of the RAF in preparing these vaccines is small, as they're made by a staff engaged in numerous other duties and created out of germs which cost nothing. So when I was thinking, gosh, I'm not sure this is necessarily the boss I would want to work for. I think everyone else seemed quite busy with outbreak investigations, but he's bunged the whole vaccine thing on them as a cheap extra. So I think they were probably working beyond their pay. But nevertheless, it certainly advanced the global science of vaccination. So I think we have to be grateful to him. And this did mean that the IPTM was one of the most significant global innovators and manufacturers of vaccines. And during the interwar years, and stock vaccines were developed and produced according to service needs, but they covered an enormous range of diseases, from influenza, of course, gonococcus, staphylococcus, typhoid, paratyphoid, cholera, salmonella, tetanus. And there were collaborations with the private sector too. So there were collaborations with Glaxo, which further drove the science and production of vaccines and scientific discovery to develop stable vaccines that could be transported over geographies, which is another challenge. And I think it also benefited from its location being near Oxford at RAF Halton. So it benefited from that close community of medical innovation and medical science at the time. So certainly I would make the argument that IPTM was at the forefront of vaccine research. So by the time the Second World War came around, the RAF actually did have a mature service for vaccine development and production, which was a real gift in some ways of RAF medical services to the wider war undertaking. However, as in so many fields, the war revealed new requirements for this small, overstretched establishment. And it revealed new requirements that the RAF had to take seriously. And the first was medical logistics and the delivery of medical supplies, such as blood, vaccines, oxygen to dispersed British and Allied troops. And the second was aeromedical evacuation. So the carriage of unwell servicemen via air by specialist medically provisioned aeroplanes and clinical teams. And both of these tasks are challenging in their own right, in different ways. So medical logistics is not as simple as simply just flying a box of something from A to B. We've seen during COVID how difficult it is just to move boxes of masks around the country. So the challenge, for example, of moving blood, which was a critical function of the RAF provision during the time, is immensely complicated. I think blood is actually an interesting thing to pick up here. We were speaking about it earlier. Most war casualties that suffer significant trauma will require a blood transfusion, and outcomes are generally better if you can transfuse early because you stop them from dying. Now, it's a bit more complicated than that, but that's a sort of rule of thumb on the whole. But blood is a difficult product. It degrades rapidly. It likes to be at a particular temperature, and it doesn't just sit tight in a box for a while and then it's perfect 6 hours later or 12 hours later. I can't tell you the nights I've had where I've taken a simple blood bottle from one ward to the lab in the hospital to be told to go back and bleed the patient because it's not survived me carrying it on a lift. So to transport vast quantities of blood across the geographies that we were talking about, across battlefield territories at the time, is both a sort of very important strategic and tactical level capability. It's also important for force morale. And actually, I'm going to make a plug here for one of our colleagues at the King's Centre for Conflict and Health Research. He focuses on medical logistics and with a specific interest in blood. So that's Colonel Ron T, if anyone wants to read up on that. And I've given him a plug, so get some commission for that. But Whittingham and the IPTM really did direct a huge effort at developing this capability. And you can see it says their army blood supply. And they essentially used a version of dry ice. which is still what we use to transport many medical products today and have been used in recent operations by the RAF. So that kind of key idea of transporting blood in a cold way changed the nature of trauma systems and changed the nature of trauma management supported by the Air Force during the Second World War. And to give you some kind of sense of the quantities we're talking about, Whittingham has written that from D-Day to March 1945, 186 tons of blood were transported by air. That he made during daily 1,624 pounds of blood. It's an enormous quantity of blood to be transported, and that's an enormous quantity of blood to bleed from any population, let alone to then transport safely in a way that it survives the carriage and is worthwhile to transfuse at a later stage. So another very, I think, important and significant outcome of the IPTM work. And the second I mentioned is this issue of aeromedical evacuation. So the Second World War, as I mentioned, of course, took place over new geographies, and the burden of trauma and disease that needed to be repatriated across these geographies escalated. So field trauma systems had been developed during World War I, and there was a good understanding of the need for early intervention on the battlefield and the transfer to forward operating base networks and field hospitals. However, the severity and scale of injuries that was produced in this war was beyond the scope of local field hospitals. For example, you had severe burdens of burned airmen. There was the amputee hospitals back in the UK, and simply the scale and burden required new approaches to transfer unwell, complex, polymorbid patients at speed. And that was the challenge that was posed to the RAF and the challenge that Whittingham took on. And it's hard to overstate the impressive, and I think this is one of his most impressive achievements, the rate that he expanded this medical evacuation service. So again, by Whittingham's estimations, in 1940, 200 British servicemen were evacuated by air. In 1943, he reckons that this number was around 40,000. So the science of aeromedical evacuation may have been nascent, but as ever, Whittingham's team was fastidious and obsessive. And this involved a group much larger than the IPTM alone. It encompassed the full scale of RAF air power to return injured and unwell servicemen to safety. And much work went into determining what cases were fit for transfer by air and which ones were not. So, for example, if you had a pneumothorax, which is a collapsed lung, you could not be evacuated by air because of the pressure, which makes sense. You couldn't be transferred by air if you had facial trauma, again, because of the issues maintaining airways at altitude. And there were other issues. But still, the numbers were enormous. The highest number in one single day was 934 casualties transported by air, which is really spectacular for this sort of add-on service that's been taken up. And you can see these networks on the notes that he's made. This is his own hand drawings of the networks of flights that he's constructed for field evacuation. And in fact, it was this achievement that constituted one of his proudest career achievements. He's written some very sweet speech notes where he's reflected on this program, and he notes kind of important lessons for health planners today. He says, build as you go and respond rapidly. We heard Mike Ryan, the head of health emergencies at the WHO, say something very similar to that in a recent press conference. And finally, he's written that the work of this aeromedical evacuation that contributed to the RAF truly earning its motto, per adua ad astra. So he really felt that this was a spectacular achievement in his kind of grand opus. And he achieved a number of things. And I won't even talk about most of his aviation, medicine, and physiology work. And of course, aeromedical evacuation and transport of medically unwell individuals remains a highly specialist capability of today's Royal Air Force. And this was well demonstrated during Operation Gritrock, which was the British deployment of forces to support the Ebola response in West Africa in 2014-16, which up until 2015, for example, the Royal Air Force was the only organisation that transported individuals that suffered from high consequence pathogens such as Ebola or Lassa fever. And the long-standing expertise of the RAF in aeromedical pathology can indeed be traced from Whittingham's early work in setting the RAF aside as a unique organisation with unique capabilities in this important area. More recently, Operation Broadshare, which is the operation dedicated to the COVID-19 response abroad. So the RAF has again been highly visible in transporting stuff. But as we've discovered, it's not that easy just to transport stuff. It's transporting things like blood, vaccines, essential medicines, oxygen, as far away as Antarctica, repatriating British nationals, delivering medical supplies on behalf of NATO to Africa. The RAF's capabilities in military medical management, military medical response remain at the forefront of national capabilities, which I think is something the Air Force can be very proud of, and I think can be traced to much of this early work that was carried out at various kitchen laboratories and latterly more sophisticated entities. So you'll have to indulge me touching on my own personal focus. My work focuses on the issue of global health security, and that's really focused on the concept that pathogens, bugs, bacteria, viruses, anything like that, constitute cross-border threats that threaten the health of populations and require specific solutions that sometimes involve security actors, sometimes involve civilian actors, sometimes involve anyone you can think of to respond to them. And the RAF, so the Army and the Navy have been quite vocal about their contributions to global health security, and the RAF less so, and I think that's a shame. But Whittingham was an important, and as usual, he was quite ahead of his time in his understanding that the evolving nature of the Royal Air Force, and in fact the evolving nature of aviation, was going to change the face of global health. He understood that as aviation, which he was passionate about, expanded, that was going to pose new risks to global populations. One of the fundamental understandings at the heart of the global health security agenda is that in a globalized world, pathogens can spread in hours through air travel. And Whittingham was very clear from very early on that aviation had to attend to that threat, and the Royal Air Force had to attend to that threat to its own populations and to the broader global community. So I would make the case very strongly that the RAF is actually a central actor in the building of the health security agenda through those early understandings that were developed. And in fact, Whittingham, in his role as a representative to the International Air Travel Association, contributed to the new WHO's new international set of regulations. So he was involved in the drafting of what was called the International Sanitary Regulations, and it does get more exciting than a bunch of regulations, I promise. But these came into effect in 1951, following the Second World War. The WHO was established following the Second World War, when there was this understanding that actually the health of global populations couldn't just be left to chance, couldn't just be left to national governments. There was a new world order, the UN system was coming to the fore, and health had to be central in international efforts. So again, it was Whittingham, bringing all his wealth of experience, was at the table negotiating, developing, and strengthening international approaches to this work. And in 1951, on May the 25th, the Fourth World Health Organization Assembly unanimously approved these new WHO sanitary regulations. And these were approved by 64 member states, which were the first time a single set of rules concerned international traffic of any kind, international trade. Previously, the various piecemeal sets of regulations kind of covered a bit of maritime law, naval trade, quarantines in ports, which, over these timescales, in theory, would be a little bit easier. If you bring a disease within a ship, you can contain it clearly within a port. Harder to do with lots of moving planes in airports, right? So that was the threat that this had to tackle, and Whittingham was clear. And the program involved, instead of integrating this international health organization into the international legal rules of infectious disease control. So we can see that international cooperation on infectious disease management is still not amazing. But I do think we have individuals like Whittingham to thank for driving so early that focus. And I do think we can see the current structures that we have as an aviation-infused international health regulation system. That may be a stretch if I was with my international health colleagues, but I do believe that, because that is the fundamental anxiety at the core of global health security, so that stuff moves quickly and we're always behind. We're on the right-hand side of the curve when we should be on the left. And that's the fundamental role of these regulations. So, it was clear by 1951 that the regulations that were in place during the war weren't fit for purpose. They weren't led by anyone centrally, and they weren't working, most importantly. So if such matters do seem rather abstract, we should reflect on their continued significance in our own daily lives. So we are governed, all of us, in various ways by the international health regulations, again led by the WHO, which in theory regulate what our governments should be doing in the event of an early pandemic, potential outbreak, an early potential epidemic, or any real significant health emergency of international concern. That's the core phrase at the heart of the international health regulations. And when people in the media and in governments criticize governments for concealing or delaying their declaration of any kind of disease outbreak, they are directly invoking this set of regulations that was developed on the basis of concerns around escalating air travel and globalization because of aviation's involvement in international health. And they were reformulated yet again after SARS-1 in 2003 because of the concern that actually the air traffic industry wasn't being sufficiently represented and was too vulnerable following the course of that epidemic. So we see these issues coming alive, and we ignore, I think, the lessons at our peril, and they come back to bite us over and over again. But Whittingham and the work of the RAF Medical Services, I would argue, very early on managed to, we talk a lot in my field about how do you translate policy into practice. Well, it's a pretty good translation of policy, or of policy into practice and practice into policy, to get your fundamental anxiety into the set of international health regulations, where it remains to this day. So I won't dwell too much on the latter half of the 20th century, but simply to say that there's so much, this unit has a wealth of fascinating, you're all picking out your friends in the picture, aren't you? But it does have a wealth of fascinating history, and there are so many functions that were developed at the IPTM, which I had the great pleasure of discussing with individuals who had worked there at the time, not least the advanced skills developed in aviation pathology and the involvement of IPTM in every important air crash involving on British soil and involving British people overseas. So that's from Comet to the Trident Heathrow crash to the Herald Free Enterprise, Lockerbie, Piper Alpha, you name it, they were there. Which again is an exceptional capability and merits a book in itself, to be honest with you. But in the late 1990s, sadly, the IPTM was closed, alongside many other defence medical services, which were reorganised and integrated into defence medical services in new ways, which I'm sure you all have your own experiences of. And so the building itself, with the sign on it, doesn't exist anymore. It was knocked down. If you go online, you can find there's some enthusiasts who like to go around dilapidated medical buildings and other buildings, and you can see them going through the old hospital. It's quite sad because you see all of the old tools and the incubators and other sort of devices for the hospital still there. They're not there anymore. It's now a block of flats at the edge of RAF Halton. But we certainly, I think, can reflect on the important remnants that this unit and the people and the work of this unit have in not only today's RAF and the wider military medical defence establishment, but in today's global health. So I leave you with a picture of the sign where it was found this morning. Can anyone guess where that might be? So it's actually my living room wall. So I'm grateful to you for helping me settle an interior design dispute in my family. I said when I put it up without asking anyone's permission that it was important, it was actually for work. And now I've made it for work, and you've all had to listen to me. But I have many people to thank for allowing me to present tonight. Harry Raffle and the Royal Aeronautical Society, the RAF Museum, Group Captain Andrew Green, who was very helpful in providing me with lots of information, Mr. Peter Allen, Mr. William Butts for information as well, which came through as immensely helpful, and many others who I can't thank. But I hope that the work of the RAF IPTM still continues in some way or shape or another to influence today's global health. So thank you very much for your time, and I'd be happy to answer any questions. Thank you.
Okay, well, thank you very much for that, Gemma. So I can just step over these chairs. And I think quite the opposite of having to thank me and the society, it's us who will need to thank you. It was a very interesting lecture. We do have, for our online audience, the ability to ask questions. You can use the ask a question function. And if you do that, I will pass the microphone to Sam Collins, who's kindly helping us today. But first, do we have any questions in the room before I mobilise my time? Yes. Yes, there you go. Yes.
Thank you very much for that, Gemma. And firstly, I'd like first refusal on that sign when you take it down
Yep.
off your living room wall, if that's okay. I was interested in Whittingham's work in designing the Air Force's own vaccine. I was just wondering if there were anything in his notes or his records that spoke to any concerns about vaccine hesitancy in the RAF population that he was delivering that vaccine to, noting that we're in a very different era now with informed consent, and we won't get into vaccine hesitancy. But was there any mention or discussion of that?
There is a bit. So he talks about that he's very detailed on the quantities and the amounts and the makeup of the vaccines. But in his operational logbooks, he also writes about where he gets to and where they get delivered. He does write a little bit, not in detail, about the concept of hesitancy, which I think wasn't well acknowledged in perhaps the sensitivities that we have today around the reasons, but he did acknowledge that lots of people didn't like the vaccines. There were side effects to certain kinds of vaccines, and that particularly young air crew might sometimes avoid some of the vaccination drives. It would have been very interesting to do studies into why and what kind of sensitization might be required in specific populations. But he does touch on it. He made very detailed notes on all sorts of things, and they are distributed at the Wellcome Archives, where there is a whole Whittingham archive there, as well as all the operational logbooks, which are at the National Archives. So vaccine hesitancy in the RAF actually would be a very interesting topic.
Thank you. If I could just add to that, as a former Royal Air Force medical officer, the vaccine hesitancy isn't encouraged. And certainly when I served, it was a legal order for a commanding officer to require someone to be vaccinated. He or she could, of course, still turn it down, and the medical officer certainly wasn't going to give it to anybody who didn't want it, but it did put the likely recipient facing a charge of failing to obey a lawful order. So that colours the picture somewhat.
I thought a really interesting point which came out was him wanting to use the vaccines to keep money within his department, which I think anyone who's had a budget and needs to hold on to it will understand. I do wonder whether or not that also fed into a cultural idea within the RAF, where perhaps we've also talked about they didn't give enough perhaps recognition to their medical services in comparison to the Army and the Navy. The Navy, of course, always go around bragging. We all know that. But for the RAF, do you feel that in the interwar period in particular, and medevac as well, that these areas were neglected, perhaps because of a culture within senior leadership around giving funds to institutes like this?
I think that's reasonable, actually. And I think what Whittingham intelligently, but perhaps didn't well communicate early on, was that I think early on, the central laboratory was developed as this capability that was for doctors to support a specific population or medical services to support a very specific population. But what he really did was he identified that actually the demands of military aviation placed new demands on the human body and produced disease in new ways. And that was a remarkable insight. And perhaps, the reasons why, I'm sure there are many. I think in some ways he was so preoccupied with developing this very, very lively research agenda within the unit. He didn't necessarily focus on communicating that outwardly across the services. So he communicated very well across aviation, and certainly he's very well known within military aviation medicine. But I think that in those interwar years, it was very much focused on kind of retrenching, developing the vaccine capability, supporting the troops to be vaccinated. He spent a lot of time doing visits to RAF stations and doing the very boring nitty-gritty stuff of public health, going into the plumbing and seeing where the leaks are, fumigating rooms and working out how many flies were left in it. Important, essential work, but often neglected. It's not the sexy work that gets so much publication, but it's so important to all the basics of public health. Like I said at the beginning, the best public health work never gets seen. It's like housework. You don't notice it until it stops.
Really interesting. Okay, do we have any questions in the room? Okay.
So there's two comments from the online audience. Dale Dabben says, Gemma, sorry, no mic available. We have a picture of Sir Harold on the wall in Air Command and still celebrates his life through the annual award in his name. In fact, GP Captain Andy Green is a double winner of it.
I'm not surprised.
His widow would attend the prize, giving luncheon until her passing in the early 2000s. And then
I have a picture of his widow attending one of those events, actually. Yeah.
interesting. Then Mark Bailey says, Gemma, thank you. That was excellent. With regard to the RAF badge for the Institute, does anybody know what the various components mean?
That's a very good question, and I don't know. You might have to ask Andy Green, or there might be someone in the audience who knows.
I think the sort of red seven-looking
Should we go
wiggly
back?
thing is a phlegm. Now, exactly what you use it for, I'm not certain. That one there, yes, they went out of use some time before I was in practice, but I think they use them to access blood vessels.
Ah, that would make sense, given the work of the unit and because it's quite hard to find quite hard to find the crest. I found one copy on a pamphlet, along with the others. There's the hospital that was there as well, and then the other very helpful supply of this was on Captain Green's rugby top that he had from the time, which I do have a picture of. So again, I'm grateful to Andy Green. Thank you again.
Mark Bailey also says, thank you, Andy. Also, Gemma might be interested to know that we had significant problems with sandfly fever in Helmand, Afghanistan, and there is a good account of an outbreak that occurred in World War II in Spike Milligan's autobiography.
Oh, very interesting. Thank you. I'll go and read that.
Okay, so we've got a question in the room.
Coming up to date, the new organisation or organisations are taken over. Can you comment how they're working? Is it a better integrated system between the services?
I don't think I should comment on that. I think we should ask the experts in the room, actually, of which I know there are many.
Do they want to offer an opinion? They do, desperately. Which one?
Yeah, so obviously we have our special unique selling points. Aeromedical evacuation remains the one for the Air Force, but it effectively offers something unique to defence organisation. And Defence Medical Services really brings us all together and exploits all the benefits of the three different services. So, there's always going to be tensions between different organisations delivering different products, but effectively what you get from bringing the organisations together is the best of all the different environments and all the benefits that we can put on behalf of UK defence. So, I think joint is the way forward. We've been operating in a joint environment for many years now, and it's the way to do business. I think budgets is way above our pay scale. We deliver what we need to deliver, and from a healthcare perspective, we're there when the country needs us to deliver what we need to deliver, wherever it be.
I think wisely sidestepping the budget question. I should say it's really lovely to see so many members of medical service here. One of the things the museum was really keen to do is collect more stories because, of course, during COVID, we realised we haven't done that very well previously. So if you would like to be interviewed, then do please come and speak to us at the end, both past and present. Very interested in capturing those stories. Because I was saying to Gemma beforehand, actually finding a picture to go for this topic was quite difficult. And when I saw your first slide, when you sent it over initially, I thought, oh, well, maybe I need to tell somebody they need to get hold of this sign. It's too late. So that's a shame. But I should also say for the crest, the Orrick Museum's archive does have a complete book of all the heraldry for the different squadrons and units. So you should be able to find it there. If you do want a slightly higher res version. And since you've given a talk, we could probably do that for you.
Thank you.
Do we have any questions in the room? We've got one online. Okay,
So David Ruddleston, he says, did the aeromedical service in World War II involve just the provision of aircraft and clinical teams, or were mechanical, electrical and/or gaseous airborne equipment developed by the IPTM? So did they develop the
I don't know if it was by the IPTM itself, but there was very little in terms of what we would recognise as the kind of tools that you need for it. There are some very nice pictures, but they are essentially stretcher bays with and there's he's made lots of notes on the first aid requirements, and it's pretty basic what was supplied at the time, things I don't think I could work with in a full hospital, let alone a moving aircraft with incredibly sick airmen. But the results he publishes, whether they are true or not, I hope they're true, show quite good results. But that may come down to how he picked the populations, and he did take a lot of time and care to pick the right patients for the right time for the right kinds of transport. Perhaps that is part of the art of aeromedical evacuation as well.
Great. Any other questions? Whilst you were thinking about it, otherwise you'll regret it as you're heading home. I found it really interesting thinking about it. This series is subtitled the Trenchard Lecture Series in Air Power Studies. And so it might seem slightly counterintuitive that medical services fit within that. I think clearly seen that they do. The logistics aspect you talked on is a clear ability to implement air power as well. But is there, perhaps in the modern day particularly, a need to think about health power? I mean, would we be better conceiving health in more strategic ways? Is that one of the limitations we've suffered from, that we see it as this thing we execute amongst the civilian population, and it's their sort of responsibility? And if we thought about it more strategically as a sort of health power concept, we might be able to achieve more.
So yes, so this is actually a highly contentious topic in the field of global health security, and it can be highly polarizing. My belief is that it can be when done well, and that is sort of one of the core concepts at the heart of what we do in the health security field, is to say actually there are enormous benefits to I hate the word, but hybridizing all of the various tools and capabilities across these sectors, and to really see that as an important strategic capability of nation states, and to be sort of agnostic as to where it comes from in a way, as long as it's done well and effectively and planned appropriately. But there is a long and difficult history of the inclusion of health within security and kind of strategic mandates, which goes back a very long time, and some groups quite rightly have enduring problems with. So there's a long-standing, in the sort of civil military space around medical provision, there's kind of long-standing antagonisms between, say, the humanitarian community and the military community, and so often those collide in spaces, particularly in which the conditions I often work in conflict, where all sorts of different actors are delivering all sorts of different kinds of care, and perhaps you can't be quite as fussy as to who's delivering what, when, and why, and where. Obviously, I think it's clear that military services in these environments can bring an awful lot to the table. Medical logistics is an absolute capability that has been brought to bear during COVID. So military medical logistic planners supported the national effort for medical logistics across the whole country. And I think that is a good example of that integration as a sort of wider strategic capability. There are other areas where and again, I have my own views on these things, as lots of people do, where perhaps I think it's less appropriate. But I think, for example, the new UK Health Security Agency is, I think, part of an acceptance of this new role for securitized approaches in health to become central national operational tools in the health sphere. What that ends up looking like is going to be very different in lots of different places, but that's kind of an open question.
What's your opinion on different national different national characters when it comes to how states relate to and how people relate to the military's involvement in medical health? So I know, for instance, with the Swiss, somebody I did my master's degree with, he is obviously does his national service with the Swiss military. And one of the things the Swiss military did straight away in the COVID pandemic was set up field hospitals to move patients into there so they could use the actual hospitals for COVID patients. But that is something which the British public, I think, would be very hesitant to pass over to the military. And so at the start of the pandemic, there was a lot of people questioning why the military weren't involved more in a lot of the logistics side. Is that to do with different national relationships between the public and the military?
Yeah, definitely. That's definitely a part of it. Kind of the national appetite for the militarization of health is, as you like you rightly point out, it's highly variable. It's worth saying that there's no EU country where militaries weren't used in the COVID response in some way or another. But those roles were very different across different roles, and as you say, some were deployed much more early. So here, quite late, I think there's a real aversion to this idea of boots on the ground uniforms. I mean, those of us who aren't military, we weren't even allowed to wear masks initially because it was thought it would scare the patients, let alone turning up in some kind of military uniform. Obviously, that changed. Whereas in other places, yes, I think it reflects historical practices, as you say, which are variable. And actually, it's something that we look into as well. So across Europe, where the militaries are more lateral to the central national health provision, there are decisions to be taken about when to introduce people in a health emergency. But there are other settings where militaries are the bread and butter day-to-day major medical provider in a health sector. So to say, oh, it's a military doctor giving me treatment in Egypt, big deal. It's who cares? That's of course, or Bahrain. That's just par for the course. So yes, but I think there can be people can move very quickly to one side of the divide, saying yes, we've got to bring militaries in really early in these things. That's really good, and we'll just solve the problem. But you talked about character. Military people do think about things in a very particular way, and there's an argument to say that the people outside the military think in a very particular way as well. And I think that perhaps the better effort is to plan early what you're going to do, so that you're not having to make it up on the fly. And that's when you're really going to upset people, and that's when you're going to have issues around hesitancy and people not wanting to turn up and the reticence to get tested and all that stuff. It can all work. We know civil military collaboration can be really effective. It's been effective in lots and lots of case studies, but it's contentious. And so if you don't plan, if you fail to prepare, you prepare to fail. It's as simple as that.
I think just in answering that, it's probably worthwhile mentioning from an NHS perspective and from a DMS perspective that our medical staff are naturally embedded within the NHS. So military staff are consistently working within wards, within hospital theatres, across the whole range of specialities. And therefore, when the pandemic started, we're already embedded within the NHS. So therefore, removing them to deliver in a different way would have taken them from the trust within which they work. So they're already providing that response within the system.
Yeah.
People might not realise that, but they're there and they're delivering on a daily basis.
It's a very important point, actually. Yeah.
Just a practical question. Long time since I've been on an aeroplane, but the vibration of turbo is probably higher than on a jet. And what is the condition of the blood for being vibrated that much on a journey, or is there no problem at all?
That's a very good question.
Well, cavitation, I'm worried about. And there's another thing I've been told that blood doesn't, if it's frozen, it becomes
in regards.
analysis.
This gentleman can answer your question.
It doesn't reduce the life of it at all. It's still viable for 35 days.
No bubbles?
No, it's all good. So the practices that were practiced back in the Second World War, we're still doing exactly the same practices today. And there's no potential blood.
And you can freeze blood.
Excellent.
I know from the control that when the liquid is broken, that you have to take blood, which is more invasive. And the guy who discovered how to detect growth hormone from blood said that we have to have one of those thermometers inside. And be very careful about the handover situation.
I'm sure the gentleman behind you is more the expert, but certainly it's a delicate product and has to be looked after in transport very carefully.
Okay, so do we have any more questions either online or in the room?
Somebody just asked if you can still see the old building.
No, you can't. It's a block of flats. It's not even the same building. It was knocked down and they started again. It's quite an ugly block of flats, unfortunately.
Gemma, thank you. Can I just ask about the impacts of the operational epidemiology? Where can we see the developments of the medical intelligence and the procurement of medicines to the various regions that are deployed to recognising the patient returning even as their origins? How did operational epidemiology develop?
I think this work was absolutely pivotal to medical intelligence, and I mean, medical intelligence really just focuses on that kind of here at least the force protection elements and the information required to monitor military populations, or certainly at the time that was the major focus. And as you say, the geographies that are involved meant that in some ways the study population grew, right? So epidemiology is always improved by having a bigger sample to see more. And Whittingham and the work of the IPTM was really focused on kind of all diseases. It didn't have it had to respond to everything, new, old, emerging. So all of the tools and techniques in kind of the outbreak epidemiology and the outbreak investigations, which carried on, and Andy Green can tell you much more about all of his work in outbreak investigations, I think was absolutely fundamental from a very early stage. I think that's one of the major contributions actually of this unit, is the sort of active, rapid epidemiology that was deployed. And if you go through his notes and the archives on this, he's really very detailed. It may all be hand drawn and done on you can see he's done it with a ruler, and it's beautiful, but it's absolutely rigorous, the epidemiology, and is still kind of a high standard that actually those of us doing this work should still aspire to.
Okay, well, I think that's a really lovely point to end on. Before I ask you all to thank Gemma again, I thought it was a great lecture. You should do more history. You've clearly got a talent for it. I think it's a good point for me to say we'll be back here on the 12th of May when John Peaty will be talking about Ital Balbo and the Regia Aeronautica. So a slightly different topic. That's a change to what is currently on the Royal Aeronautical Society's diary, but all those details are online. Before then, we'll have a virtual lecture on the 1st of April, where it's on the Falklands in 40th anniversary. And it's going to be a very timely presentation because it's considering what militaries today could learn, and apparently there are quite a lot of lessons for Russians. So hopefully they won't tune in. But if you're more than welcome to come again to the Royal Aeronautical Society, who we're very grateful for hosting us today. And I think we'll all share our thanks to them. It's been lovely to be here. We've been out on the balcony overlooking Hyde Park Corner. So, if you're online, certainly should have come. It was very sunny. But yes, a huge thank you to everyone who tuned in, and very much a thank you to those of you who've made the effort to come here today. But in particular, thank you, Gemma. It's a really enjoyable lecture.
Thank you. Thank you.